What if the very tests your doctor orders to keep you healthy are actually the ones putting you at risk? Not because of some medical conspiracy, but because the math changes dramatically after you turn 70, and almost no one in that exam room is doing the calculation out loud. Today, I'm going to walk you through 5 routine medical checkups that could be doing more harm than good if you're over 70, and I'll give you a set of powerful questions that will completely transform how you handle your next doctor's appointment. This is information your physician may never volunteer, and honestly, it might be the most important 20 minutes you spend on your health all year. Before we go any further, if you're new here, please subscribe right now. My name is Dr. Jacob Allen, and every single week I break down what the research actually says about aging, health, and medicine. In plain English, no textbook jargon, no corporate spin. Hit subscribe so you don't miss a single video. Now let's get into it. Picture this. You're 76 years old. You feel genuinely good. Not Olympic athlete good, but solid. You're sleeping. You're eating. You've got things in your life that bring you joy. You walk into your annual checkup with nothing specific on your mind. You're just doing the responsible thing. Your doctor flips through your file and says, almost as an aside, "You know what? Let's run a few tests while you're here, just to be thorough." You shrug and say, "Sure," because that sounds reasonable. That sounds like exactly what a careful doctor should say. 6 weeks later, you're sitting in a surgeon's office, not because anything hurt, not because you noticed a single symptom, but because those just-to-be-safe tests found something. And what followed, the referrals, the imaging, the procedures, the interventions, set off a chain reaction your body at 76 was simply not equipped to handle the way it might have at 55. The calm, independent, satisfying life you were living before that checkup, it now looks completely different. And not in the way you were hoping. That is not a hypothetical. That scenario plays out in hospitals across this country with a frequency the medical system doesn't exactly post on its website. And the evidence behind it is serious enough that you deserve to hear it clearly, honestly, and without someone softening the edges so much that the point gets lost. Here's the uncomfortable truth that almost never gets said in a 15-minute appointment. After the age of 70, some of the most routine, well-intentioned medical tests can actively cause more harm than the harm they were designed to prevent. Not because your doctor doesn't care about you, not because medicine has failed, but because the risk-to-benefit equation shifts significantly as we age, and in most cases, nobody is stopping to run that equation out loud with you in the room. I want to give you one framework before we walk through the 5 checkups, because without it, what I'm about to say might just feel like a collection of surprising opinions. I call it the longevity lens. Once you understand it, a lot of things in medicine will start making a different kind of sense. When you're 50, early screening is genuinely brilliant medicine. You catch something, you treat it, and you potentially add decades of healthy life. The investment is absolutely worth it. The logic holds up. But after 70, 3 things change, and they all matter in a big way. First, many conditions that screening catches in older adults will never actually hurt you. These things grow at a glacially slow pace. They produce 0 symptoms, and in many cases you'll simply outlive them. They're biologically present, but clinically irrelevant. Here's the problem, though. Once a finding shows up on a report, the medical system doesn't really come equipped with a "let's just watch it and leave it alone" button. It comes with a treatment button, and that button tends to get pressed. Second, your body's capacity to bounce back from medical intervention declines with age. That's not a criticism of anyone, that's physiology. A procedure that a healthy 52-year-old recovers from in 10 days might mean 3 months of difficult recovery for a 78-year-old, along with complications, reduced mobility, and in some cases a permanent shift in quality of life. The same intervention on 2 different bodies at 2 different ages is not the same procedure. Third, and I really want you to hear this one, there's something called the cascade effect. One test finds a small abnormality. That finding triggers a follow-up scan. The scan points toward a biopsy. The biopsy leads to a procedure. The procedure causes a complication. And suddenly, someone who walked in for a routine checkup feeling perfectly well is navigating a medical situation they never expected and, in retrospect, never needed to be in. Not because of their disease, because of the test they agreed to on an ordinary Tuesday afternoon. That's the longevity lens. Hold it in the back of your mind as we go through each one. Here we go. The first one. Routine colonoscopy after age 75. Let me tell you about a woman named Margaret. She was 77, a retired school administrator, living independently, sharp as a tack. She'd had 2 colonoscopies in her 50s and 60s, both completely clean. No polyps, no family history of colon cancer, no symptoms of any kind. When she switched to a new primary care doctor, he looked at her file, noted she was due, and recommended she get another one. Margaret had some hesitation. She'd done a bit of reading, but she didn't want to seem like a difficult patient, so she went ahead. The bowel prep, the large volume laxative solution you have to drink the night before to fully clean out your colon, hit her kidneys harder than anyone anticipated. By the following morning, she was confused, unsteady, barely able to get out of bed. Her son took one look at her and drove her straight to the emergency room. Severe dehydration. Electrolytes at dangerous levels. Her heart under strain. Margaret spent 4 days in the hospital and never actually had the colonoscopy. And here's the part that really stays with you. She didn't need it in the first place. The United States Preventive Services Task Force, the leading national body that sets screening guidelines, officially recommends against routine colonoscopy for average-risk adults aged 75 and older. The evidence is clear. If you have no symptoms, no family history, and your previous scopes were clean, the risks of the procedure at that age begin to measurably outweigh what you're realistically going to gain from it. And those risks are not theoretical. Bowel perforation, an actual tear in the colon, occurs in roughly 1 out of every 500 colonoscopies. In a younger adult, that's a manageable surgical complication. In a 77-year-old, it can mean emergency surgery, extended hospitalization, and a recovery process that changes daily life in ways that don't fully reverse. Meanwhile, the colon cancers most commonly detected in asymptomatic older adults tend to grow so slowly that, in many cases, they would never cause harm within that person's remaining lifetime. The disease is technically there, but it was never going to be the thing that got them. What's the smarter approach? Ask your doctor about stool-based screening, tests like Cologuard or the annual FIT test. These can flag genuine warning signs without exposing you to procedural risk. And to be absolutely clear, if you have actual symptoms, blood in the stool, unexplained changes in bowel habits, persistent abdominal pain, that's a completely different conversation. Get evaluated immediately. Don't wait. But routine screening after 75 in an asymptomatic average-risk person, that's worth a serious discussion before you just say yes. The second one, aggressive PSA testing and annual mammography in low-risk asymptomatic patients. I need to be careful here, because this one gets misread easily, and the stakes are too high for confusion. I am not for 1 second, saying cancer screening doesn't matter. It absolutely matters. It has saved millions of lives, and it may save yours. What I am saying, very specifically, is that aggressive cancer screening after 75 in average-risk individuals with no symptoms has a serious and well-documented overdiagnosis problem, and overdiagnosis leads, almost inevitably, to overtreatment. Here's what overdiagnosis actually looks like in the real world. Modern imaging is extraordinarily sensitive, almost uncomfortably so. It can detect cancers that are, biologically speaking, barely moving. Tiny, slow-growing tumors that, if left completely alone, would never spread, never produce a symptom, and never shorten your life by a single day. You would die with them present in your body, not because of them. But the moment a radiologist puts the word malignancy on a report, the clinical machine activates. Biopsies get scheduled, specialists get called, treatment plans get drawn up, And all of that moves forward largely, regardless of whether that particular cancer posed any real threat to your life. Think about someone like Gerald, a 79-year-old retired engineer, still sharp, still active, still playing golf twice a week. His routine PSA came back slightly elevated. A biopsy confirmed a low-grade, slow-moving prostate cancer. His urologist recommended radiation. Gerald trusted that and proceeded. Within a year, he was dealing with chronic fatigue, significant urinary complications, and a quality of life he barely recognized. His type of cancer, slow-growing, low-grade, detected at his age, is the type that, in many well-documented cases, could have been monitored rather than treated. Had he known the full picture going in, his decision may have been entirely different. Research published in major medical journals has demonstrated that a meaningful portion of cancers caught through mammography in women over 70 were clinically insignificant, meaning that treating them provided no survival benefit at all, just side effects and anxiety and procedures and recovery time. What should you do instead? Have a real specific conversation with your doctor about your actual risk profile, family history, genetic markers, personal symptoms. Those matter enormously. If you have those factors, screen. But if you're average risk with no symptoms, try asking this directly. If we find something, what are the realistic treatment options for someone my age and overall health, and is treatment even what we'd likely recommend? That question alone tends to change the entire tone of the conversation. If you're still here and getting something real out of this video, go ahead and subscribe. I release videos like this every week, evidence-based, direct, and built for people who want to actually understand their health, not just be managed by it. The third one, routine cardiac stress testing without symptoms. This is the one that surprises people the most, because on the surface it sounds completely responsible. Your doctor looks at you and says, "You're 73. Let's make sure your heart's holding up." You get on a treadmill, or they give you a medication that temporarily stresses your heart, and they watch how it responds. Sounds like exactly the kind of precautionary medicine we should be doing, right? Except here's where the logic quietly falls apart. Cardiac stress tests in people with no symptoms have false positive rates that can reach 40% or higher in certain age groups. Nearly half the time, flip a coin plus a little, the test waves a red flag when your heart is actually functioning completely normally. But once an abnormal result appears, the system can't just shrug and move on. That false alarm launches you into phase 2, cardiac catheterization. Catheterization involves threading a long, thin tube through your blood vessels, usually entering through the wrist or the groin, and guiding it into the heart. This is a serious procedure with real risks: bleeding, vessel injury, dangerous arrhythmias, and in rare cases, it can actually trigger the very heart attack or stroke you were trying to screen for. Not common, but real, and worth knowing before you agree to it. Here's where it becomes even more counterintuitive. If the catheterization finds a partial blockage, which is extremely common in adults over 70, most of whom have no symptoms and never will, you may end up with a stent placed in your heart. But multiple major clinical trials, including the landmark ischemia trial, found that stenting patients with stable coronary artery disease did not reduce heart attacks or extend life compared to medication and lifestyle management alone. Read that again slowly. The stent carried procedural risks, required a lifetime of blood thinners, which carry their own bleeding risks, and statistically, it didn't outperform a daily walk and a good medication routine. That is not a small finding. So the whole trajectory looks like this: feeling completely fine, routine test, false alarm, catheterization, stent, blood thinners, ongoing follow-up, and you're no better protected than if you'd never started the cascade. That's not medicine working. That's medicine spinning its wheels while you pay the price. What should you focus on instead? If you have no chest pain, no unexplained breathlessness, no dizziness during activity, no symptoms of any kind, routine stress testing is essentially a search party for problems that, when found, frequently don't benefit from intervention. The genuinely high-yield work is on the actual modifiable risk factors: blood pressure, blood sugar, cholesterol, physical activity, sleep quality. That's where the real gains live. The fourth one, routine DEXA bone density screening followed by automatic medication. I want to handle this one carefully because it makes people uncomfortable, and for understandable reasons. Bone loss is real. Falls are genuinely devastating for older adults. I'm not minimizing any of that for a second. What I'm questioning is the automatic pipeline that frequently follows a DEXA scan in patients over 75, where a number on a report leads to a prescription that leads to years of medication, without anyone pausing to ask whether the full picture has been considered. Here's how the pipeline typically runs. A DEXA scan shows reduced bone density. Your doctor prescribes a bisphosphonate. Medications like alendronate or risdronate are common examples. You take them for years, trusting that your bones are being protected. Here's what often doesn't get mentioned in that conversation. Long-term bisphosphonate use has been associated with a rare but serious condition called atypical femoral fractures, spontaneous stress fractures in the thigh bone, the very bone the medication was supposed to protect. These fractures can require surgery to repair. Additionally, these medications are linked to osteonecrosis of the jaw, deterioration of the jawbone that is both painful and notoriously difficult to treat. Not common, but when it happens, it's serious enough that it deserves to be on the table before you start a years-long medication course. Meanwhile, the single most effective strategy for preventing fractures in older adults, and this is solidly supported in the research, is not a pill at all. It's fall prevention. Specifically, balance training. Studies show Tai Chi reduces fall risk by close to 50%, which is remarkable. Removing tripping hazards from the home, adding grab bars in key areas, reviewing all current medications for anything that causes dizziness, keeping vision prescriptions current, and ensuring adequate protein and vitamin D intake. These interventions consistently reduce fracture risk in ways that rival or exceed what medication alone can deliver, and they come with essentially zero downside. There are absolutely patients who need bisphosphonates, people who have already experienced fractures, those with very low T-scores, those with specific risk factors that place them in genuine danger. But a routine DEXA result leading to automatic long-term medication for an active 74-year-old who has never broken a bone and is otherwise in solid health? That's not a foregone conclusion. That's a conversation. Before accepting any prescription based on a DEXA scan, try asking your doctor, "Before we talk about medication, can we go through my actual fall risk factors together? And how does the fracture risk reduction from this drug compare to a structured fall prevention program?" See what that question opens up. The fifth one, and stay with me, because this is the one almost no one is talking about: asymptomatic carotid artery ultrasound screening. This might be the most quietly consequential item on the entire list today. A carotid artery ultrasound checks the large blood vessels running up both sides of your neck, the vessels that carry blood to your brain. The premise seems clean. If we spot a significant blockage early, we can surgically remove it and reduce your stroke risk before something happens. Logical. Intuitive. Except the reality is far more complicated than the premise, and for people with no symptoms, far more risky than it sounds. Here's the critical fact. The surgical procedure used to treat a carotid blockage, called a carotid endarterectomy, carries a 2 to 3% risk of causing a stroke during or immediately following the surgery. In older adults with additional health conditions, that risk climbs higher. Let that land for a moment. The procedure designed to prevent a stroke has a real, documented probability of causing one. That's not a technicality. That's the core of the problem. The United States Preventive Services Task Force explicitly recommends against routine carotid artery screening in adults with no symptoms, no mini strokes, no sudden vision changes, no neurological episodes of any kind. Their analysis concluded that in asymptomatic people, the potential harm from following up on a finding outweighs the potential benefit of finding it. Here's why. A large proportion of people over 70 have some degree of narrowing in their carotid arteries. It's been there for years, stable, silent, causing nothing. When you go looking for it routinely, you find it. And when a well-meaning surgeon finds it, the natural recommendation, the instinct, is to fix it. But the surgery to address a blockage that was never causing any symptoms can, and sometimes does, disturb a piece of plaque that travels directly to the brain, the very outcome everyone was trying to prevent. The documented outcomes in the medical literature across multiple studies are too significant to reduce to one patient story. What the research repeatedly shows is people entering a routine screening appointment and leaving on a trajectory nobody had planned for, not because of the blockage that was discovered, but because of the intervention that followed. What should you do instead? If you have no symptoms, no sudden vision loss, no facial weakness, no unexplained arm numbness, no abrupt severe headache, routine carotid ultrasound screening is not recommended. The far more valuable investment of your time and energy is in the modifiable risk factors that actually drive stroke: blood pressure above everything else, blood sugar management, smoking cessation if relevant, atrial fibrillation monitoring, and consistent physical activity. These move the needle in ways a screening test simply cannot. And if you do experience any neurological symptoms, even brief ones that seem to resolve on their own, get evaluated immediately. That changes everything. Now, here's the part I promised you at the beginning. 5 questions that will completely change how you show up to your next appointment. Write these down, put them in your phone, bring them every time. Question 1. What is the false positive rate of this test in people my age? This tells you how likely the test is to send you chasing a problem that doesn't actually exist, at real cost to your body, your time, and your peace of mind. Question 2. If this test finds something, what are the realistic treatment options for someone with my age and overall health? This shifts the conversation forward, not just what can be found, but what would actually be done about it, and whether knowing would realistically change your outcome. Question 3. What is the procedural risk of any treatment we'd pursue from here? Most people never ask this, and it may be the most important question on the list. Every procedure has a risk profile. You are entitled to know it before you say yes to anything. Question 4. What happens if we monitor this rather than treating it right away? For many findings in older adults, watchful waiting with regular check-ins is not the passive choice. It's frequently the wisest one. It's the choice that takes intellectual courage to recommend, and the choice most patients never hear as an option. Question 5. What is the most effective non-invasive approach for this condition? Because as we've seen today, with bone health, heart health, and stroke prevention, lifestyle changes and targeted medication frequently outperform procedural intervention, and they do it with a fraction of the risk. Any physician worth their license will not only answer these questions, they'll respect you more for asking. And if a doctor gets defensive or dismissive when you raise reasonable questions about your own body and your own care, that reaction is itself a piece of useful information. I want to leave you with something I think about often. There is a fundamental difference between medicine that finds things and medicine that genuinely helps you live well. After 70, your healthcare should not be optimized to generate an ever longer list of findings. It should be optimized to protect your quality of life, your independence, your energy, your ability to be present for the people and the experiences that matter most to you. The best physicians I've ever encountered understand that recommending less sometimes requires more wisdom than recommending more. That suggesting watchful waiting takes more intellectual courage than reflexively ordering another scan. That the right answer for the person sitting in front of you isn't always the answer that fits neatly on a protocol checklist. Medicine has given us genuinely extraordinary tools, but tools only have value when they're used in the right context, at the right time, for the right person. You are that person, and you deserve a healthcare experience built around your actual goals and values, not around what's easiest to justify on a standardized form. If this video gave you a genuinely new way to think about your health after 70, please subscribe. Every week I put out content exactly like this, honest, evidence-based, and built for adults who want to be active participants in their own care, not just recipients of someone else's protocol. And if you've ever had a routine test take you somewhere unexpected, leave it in the comments. Your story might be exactly what someone else needs to read before their next appointment. Take good care of yourselves. I'll see you in the next one.